Hello, everybody. I'm not sure whether you can hear me or you can see me. I suppose yes, because all other options, all our technical options seems to be fine. So I'm going to start with my presentation. If you want to make a question, then you can go to the microphone, press microphone, and then talk freely. We can also make like a little pause at the end for your questions, but you are free to interrupt me in between if you have any issues. So I'm very happy to be here with you in the name of the Smart Aging Swiss Academy, and we are going to. Oh, let me see how is it going? Yes, it's good. So we are going to talk about laser treatments of anogenital skin and the adjacent areas. I'm a gynecologist working at present in praxis of Dr. Rümerlein in Kilchberg. It's a dermatology praxis with all sorts of laser therapies for various parts of the body and a lot of knowledge in the laser world. And I'm in charge of the vaginal ultrasound and the ultrasound, sorry, about for the vaginal laser therapies and laser therapies in genital area. This is the first webinar I'm doing, like first time that I have to present things to other people. So if it gets funny at some points, I'm sorry. Now, at the beginning, I'm going to say that at present, the carbon dioxide laser and erbium lasers are equally good for all indications. Despite the different mechanism of action, none is currently superior to the other. Further development will, however, probably change this situation. I'm going to start with indications, so the reasons why we would use laser in this area. And the first thing is vulvovaginal atrophy. This is the name, you know it, and I wrote the GSM just behind it. I'm going to explain this. So in the 2013, the North American Menopause Society and some other societies met and decided that they want to replace the vulvovaginal atrophy with a new name, something that is more patient-friendly, more publicly acceptable, and promotes interdisciplinary communication. And so the term genitourinary syndrome of menopause has been formed as a term comprising all difficulties in the postmenopause, not only vulvar and vaginal, but also containing issues like urinary incontinence, painful intercourse, and actually all those symptoms that are found in the genital area after the menopause. I will show you these two pictures. They are the most important ones when we talk about GSM. Still in German-speaking parts, vulvovaginale atrophy as the most often used term. On the left-hand side, you can see the picture of postmenopausal vagina. You can see how thin the epithelial layers are, and on the left-hand side or the right-hand side, you can see mucosa in the reproductive age with good epithelium, good blood supply, and the appropriate thickness of the epithelium. So all the problems ensue actually from the mucosa problematics. And I'm going to explain you here why. Estrogen, as a main female hormone, is also responsible for the maintaining of mucosa. Due to estrogen influence, the epithelial cells grow and they also get filled with glycogen. Glycogen, as you know, belongs to the group of carbohydrates, and when the epithelial cells are exfoliated, it's actually like, you can imagine this like peeling in the vagina. The lactobacilli, the Döderlein bacilli, feed on these bacteria. They eat the glycogen, so to say, and then they are able to produce lactic acid, which then regulates the vaginal pH factor and keeps the normal vaginal flora. When there is lack of estrogen, like in the postmenopause, we have a very thin epithelial layer, less glycogen. There's the lactobacilli don't have their food, so they can't reproduce. The vaginal pH is dropping, and that is the situation where we have the bacterial vaginosis coming more often. Together with these problems, we have proliferation of connective tissue and hyalinization of collagen, which makes the whole mucosa to lose its elasticity. All these ongoings put together are the causes of the vaginal atrophy. In contrast to vasomotoric complaints like hot flushes, night sweats, etc., the vaginal problems are not going to go away. They are strongly associated with estrogen lack, so they start at the same time. But unlike vasomotor complaints, the vaginal changes are chronic, progressive, and present throughout the menopause and even in senium in the older age. What do our patients report? They complain about vaginal dryness, dyspareunia, the feeling of burning, irritation, itching, even bleeding during intercourse. Objective, what we can assess in our examination is the loss of elasticity, loss of vaginal folds, changed humidity, the changed quality of vaginal discharge. We can see this pale color and this thin mucosa during the examination. There is always a lot of discussion in the scientific world and also among the doctors, how many women are actually suffering from the postmenopausal changes from the GSM vaginally. And this is usually said to be a very little problem, just, you know, laser people are making it look bigger to sell more machines. But as you can see in these statistics, after 4 years of postmenopause, more than 60% of women are suffering from some form of GSM. So it is a significant number. What can we do about it? You know that the golden standard is the local estrogen therapy, but it's not allowed for all, or at least discussed controversially. Excuse me, Natalia, I'm in webinar session. Yeah. Then, sorry, real life situation. Then the therapy is also not wanted by all women, and it is a tedious application. And although we as doctors, we always think that, okay, we've solved the problem with our creams and suppositoria, actually a lot of patients complain that the cream is coming out, that it makes the lingerie always sticky, it's there in the intercourse, and it's not really the solution to all problems. Then we have the class of moisturizers. There is a large spectrum of these products. They are short-term help. Then there are either to put inside or outside. There is always the question whether the second cream should be used. It's not ideal. And then the last group, lubricants, who have different base, either oil or water or silicone. They are also short-term, and there is a huge trial and error strategy in choosing the right one. This is why we are really happy to have the laser treatment as a good option. And now so that you really remember how all this therapying is tiring, I made a funny slide for you. So you can see a man up there and a woman in the perimenopause with her night sweating, and then what she has to do in the morning, put some Perskindol for the back pain, which is also a problem of the menopause, then do some exercises or yoga, then put her vaginal estrogen cream, then put the anti-wrinkle cream. Then if you are from a dermatology, then you know you have to put a sunscreen, then you have to put compression stockings for your varicose veins, and that at the end of the story you forgot the vitamins. So if we can do something to shorten all this chain of to-dos, then we are doing good things. I will show you a few studies on laser application, and I will start here with the fractional CO2, the carbon dioxide laser, versus promestrien. It would be colpotrophine on our list, and lubricant in genitourinary syndrome of menopause. You see they had 3 groups. First group, 3 laser therapies in intervals of 30 days. Then the second group, local estrogen therapy, and then the water-based lubricant KY gel as the most prominent one. Then what was evaluated is vaginal health index score, vaginal maturation index, and female sexual function index. After 14 weeks, there was the largest increase in the vaginal health index score in the laser group, followed by local estrogen and then KY gel, which is not a surprise. But what is interesting is also the cell maturity index was higher in the laser group than in the group with local estrogenization, which tells you how potent the work of carbon dioxide laser is. There was no change in KY gel group, obviously. There was an increase in female sexual index in all groups, largest increase in the laser group, but not significant increase also in estrogenization and KY gel group, which tells you that every therapy is better than none. Then this study, also carbon dioxide laser used for vaginal atrophy, 3 treatments with carbon dioxide in 4 weeks interval, and then reevaluation after 3 and 6 months. There was a huge improvement of complaints. If you go in PubMed and start looking at these studies, you will find that all studies who tested the work of vaginal laser for vulvovaginal atrophy brought benefit. So although you hear maybe from other doctors and colleagues, no, this has not been tested enough, there is not enough data, all data that you can find are good. Now, here I will show you very, very impressive pictures done after the carbon dioxide laser treatment. You can see the same what you've seen before, this very thin epithelium, a lot of stroma, and here after Mona Lisa touch treatment, a lot of epithelium, less stroma. And here what we can see in our gynecological examination, a beautiful change in the color and of the mucosa and also the appearance of rugae, which have been lost before. And when it comes to the machines, you've heard about Mona Lisa, you are in the Mona Lisa session, and this machine has the best data so far, because in almost all carbon dioxide studies, this machine was used. So you are sure to have all the presettings. You can compare what you're doing to the settings within the studies. You know that you're doing your work with the tools which have been approved before. Now, I will show you something from the erbium laser world, so that you know I know both. I'm not just praising ones. They put 205 postmenopausal women with GSM, but also with mild incontinence, and made a treatment in intervals of 30 days and analyzed the subjective visual analog scale, done this vaginal health index score, then another score against this time consultation for incontinence. And the follow-up after first, second, and third session, and after 6, 12, 18, and 40 and 24 months, showed a huge improvement in the suffering of the patient. And what I find important for you is, because you always get this question, how long is the positive effect going to last? So here in this study, they found the effect in the vaginal health index score up to 12 months, and improvement in incontinence score after also after 18 months. So this is usually what you find in the practice, that the benefit from the laser therapy is around 12 months, sometimes a bit less, sometimes a bit more. But the good input to your patients is to say that they shouldn't wait until it really gets bad again, but that they should come when they feel that situation is not good as it used to be. So they don't start all over from the beginning. Now from GSM, from vulvovaginal atrophy, I'm going to go to stress urinary incontinence and urge. And as you know, this stress incontinence is in involuntary urine leakage in case of increase of intra-abdominal pressure and due to limited functionality of the bladder closing apparatus. It is typically connected to some constitutional reasons, or after vaginal births, or overweight. And as you know, if somebody has stress urinary incontinence, we always send these people to physiotherapy to train their pelvic floor muscles. And I'm sure you have patients who are doing this and doing fervently their physiotherapy, but they still don't have the continence the way it should be. And the explanation why this is so is that the training, the physiotherapy is working on the muscular levels, but the vaginal laser is working on the level of the mucosa. So to reach the full closure of course, physiotherapy is important, but you should also do the vaginal laser therapy. I'm showing you this erbium YAG results, because I think it's important to eliminate this talk about placebo. There is always a lot of people saying, you know, when women get the therapy, even if it doesn't work, they are happy because they had something. So there is always this placebo effect in the air. And this study, they did a trial where they randomized women to a control group and to the therapy group, but the control group had a fake therapy. They had actually a machine that looked completely like the normal machine, but without energy, and then made the patient fill the questionnaire 3 months after. And there was a significant alleviation of symptoms. So the therapy group really got some benefit, whereas the dummy group, the group which didn't have energy, they didn't have the effect. So we are definitely true that laser is doing something and there is no placebo effect, is not relevant. Now we are coming on to the overactive bladder, the urge incontinence. And this urge incontinence there are little publications on this topic. The stress has been explored better, but I will show you, this is really impressive. And these are the results gathered from Mona Lisa Touch studies, the carbon dioxide laser. And apart from vaginal atrophy situation that I already told you about, we have a huge improvement in urinary urgency. The urge is reduced. And this is what bothers women mostly. You can also see a reduction in urge incontinence. It's not so high as the urge itself, but you can still see that it's working almost as much as it's working for stress urinary incontinence. So if the women in a practice, if they ask you, is this going to do something for my urge, then you can definitely say yes. Now I'm coming to vaginal relaxation syndrome. Now, if you would want to go to PubMed and search for this, you will not find anything, because this vaginal relaxation syndrome is still not recognized by the medical public, by the medical community. And put together, this is a loss of elasticity and tension of the vagina, impaired sexual arousal due to this loss of tension, and slight urinary incontinence after childbirth. And this is one of the causes that women are coming for to the therapy. And all of them say, I've been to my doctor, or I've been to more doctors, and they all said that everything is fine and I don't have any problem, I'm healthy, but I feel that my vagina is broadened, the sex doesn't feel the same any longer, I feel that my whole pelvic floor and all the organs, it doesn't feel well any longer. And these women have usually read the literature in the internet, not the PubMed, but anything that you can find about vaginal relaxation syndrome, and they want to try, they want to have this therapy because this is really important to them. And what carbon dioxide laser is doing here, it tightens the mucosa by building up the mucosa, and by the increase of elastic fibers, the whole tissue gets more elastic, and this in turn is responsible then for better arousal. Also, with the laser, you can treat the painful episiotomy scars or painful tears after delivery, and you can use the vulva attachment for this. And now we are coming to lichen sclerosus, like sort of a real disease. We know this belongs to pathology. You know, this is a disease connected with generative changes in the dermis of the female genital area. It is associated with atrophy and hyperplasia. What we can see is the shrinkage of the vulva with sclerotic changes, and the fatty tissue disappears. It comes sometimes even before puberty in young women, and also there is a peak after menopause. It is a precancerosis, so it's like a basis for the development of vulvar carcinoma. In statistics says it's about 5% of the cases. The etiology is not completely known, and we think it's associated with autoimmune problem, so it belongs to an autoimmune disease actually. The symptoms are itching, burning pain, dyspareunia, the stenosis of introitus, and loss of tissue. In the histology, we see the inflammatory infiltrate, leukoplakia, and hyperkeratosis. The therapy is symptom-oriented. It can be in form of different moisturizers, and we all know the local application of glucocorticosteroids is important. The best known therapy is the Dermovat that is used. Now, the breakthrough in the research of how we can use laser therapy to help these women is the study by Begic. I'm showing it, showing the results here to you. There were 27 postmenopausal women with lichen sclerosus. They had treatment with carbon dioxide laser, 3 to 4 treatments at interval of 4 to 6 weeks, and then they had a vaginal microscopy and interview. In 24 out of 27 women, there was a significant reduction of itching and also microscopic improvement of elasticity and blood circulation. And if you want to know more what is happening at this scene, you should read a paper by Krapf. It's a very good paper, and it explains all the current movements and what is going on in the area of energy-based modalities, like photodynamic therapy for lichen, high-frequency ultrasound, and also carbon dioxide laser for the therapy. Platelet-rich plasma in combination with carbon dioxide laser is also coming as a method, but there are no sufficient data in the studies at present. Now I will explain our preparation, but first I'm going to close the door because the other lady left it open. Sorry, I'm back. Real life situation. Okay, before performing the therapy with Mona Lisa Touch, I always take detailed gynecological history, like you would do in your practice as well. Then there has to be a pap smear, not older than 6 months. If the patient doesn't have the pap smear or it is too old, then we do one. Time of the treatment should be outside of menstruation because you don't want the blood to mess inside. In case of lichen sclerosus, one might do a histological clarification, especially if the clinical picture is not clear. But mostly I see women who've already had biopsy and have lichen. Immediately before the treatment, I take speculum and have a look inside. I take a look how the introitus is, perineum, how the skin is, what does the mucosa look like. Then I clean the vagina with a cotton swab, with a Tupfer to be dry. And if I have a suspicion of bacterial vaginosis, I also make a pH test and a native view. The shaving is not necessary for the vaginal therapy. It is easier without hair, just from the part of the management. It's more important for the vulva treatment. So for lichen, the shaving would be a bit better. Everybody in the room has to have the safety goggles, you know, the regulations. And it's important to know that you should insert handpiece, the vaginal handpiece without gel. So the vaginal walls should be as dry as possible. We said about shaving. The application is approximately 20 minutes. Here it's written depending on the type of laser. I used Mona Lisa here in Dr. Rümerlein's praxis. I would say the time of application is also dependent of how deep the vagina is and what kind of atrophy you have and whether there has been a hysterectomy before. Because if you have an atrophy case with hysterectomy in the history, then vagina will be shorter, and this also shortens your application time. After having worked with a vaginal handpiece, you can work with vulva handpiece, and the intervention is painless except for introitus. And due to the fact that it's really uncomfortable in this area and also on the vulva, we always do the local anesthesia with Anesderm, and we apply this. The women get a bit of cream to apply themselves 10 to 15 minutes before the therapy, and then the cream gets taken away before the insertion. This is the picture of how the vaginal applicator looks like, and you can see it also has this ring. This is to make sure that you respect these little steps. So you move your probe, you move the vaginal applicator in these little steps and apply the energy. Contraindications, pregnancy. If you ask me why, I can't really say, but in the pregnancy one cannot be safe enough. And injuries or acute infections in the treatment area, vaginal bleeding of unknown cause, and menstruation. Like if women report that they didn't have their period for 2 years, but they have some vaginal bleeding, from 3 weeks on, then one would be careful about doing the therapy. The women who have history of genital herpes should be given a prescription. We prescribe valciclovir, and if they feel that there is a recidive coming, then they can apply it. If you go to the vulva, if you go to the vaginal laser literature, if you sit in front of the PubMed, you will see that everybody is like afraid of the complications that might happen someday. But from the complication that happen now, there are no severe complications. There is none case of a severe injury or any severe problem in the literature. What is usual, it's a bit swelling and redness in the vaginal area, itching, burning. It can even be painful, and change in discharge. This might get a bit more mucus, or even a bit, even a blood smear can also appear. I usually explain women that it's like having a mycosis, like having candida. It is a bit red and burns, but after 1 day, it's usually goes away. The aftercare for the therapy is optional. I find this omega-7 oil capsules very good. They are not to be put in the vagina, they are to swallow. Multigin Flora Plus, for example, to help the normal mucosa, but only 48 hours after this treatment, and you can put, for example, Cobagin outside. But this is not a must. So when you start working, or maybe you are working already, you can choose your preferences. We say no intercourse after the laser treatment for 3 to 5 days, and if there is any problem, anything that it looks that it's a bigger problem than what we talked about, the patient can always phone and we can discuss her problems on the telephone. We do 2 to 3 sessions and intervals of 6 weeks. With GSM, there's a repetition after 6 or 12 months. We instruct women that they should come when they feel it's needed. Maintenance therapy once a year is the sort of usual thing. Important, after chemotherapy or radiation, one has to wait 6 months, although new data may change this. But the worry is that due to the effect of chemotherapy, that this repair of the tissue is not going to be appropriate. What can I give you as a take-home message? First, that the laser is not an aesthetic tool, or let's say not only aesthetic, because this is how it is still called, vaginal laser. It's aesthetic, but actually no, it is not. It's therapy for medical problems. It's simple, it is safe, it's almost painless. If you put enough cream, it is painless. It's real alternative to the current therapy options. It has really good results, and there are new results coming. The amount of literature concerning laser therapy in genital area is getting really big. This is good. Study situation is good, and there is always this notion that there are not enough randomized controlled trials, but they are not going to be randomized controlled trials because nobody wants to randomize 10,000 women in group for therapy and the other 10,000 women in group getting no therapy, where it is obvious that the therapy is bringing profit to the patients. I hope you could learn something, have fun in this webinar, and I'm saying thank you for your attention. And now you can make questions if you want. Sorry, no questions?